So we have questions from the chat, which I can surface some of those now. So there was great conversation on the chat around problem lists. Problem lists in the context of US CDI version 2, as well as problem lists in the context of them being multi-specialty, who's the owner, where should they live? And then also talking about leveraging CMS 2021 E&M guidelines to reduce note bloat in the context of the use of problem lists. So while there wasn't one specific question in the chat about problem lists, I was wondering if our speakers could comment on problem lists in the context of documentation burden and requirements, as come from CMS in particular too.
I was watching particularly David Bates' comments on problem lists. The key thing from my perspective, the problem list drove the clinical decision support. So they were absolutely essential. The difference was if you build them well, they're functional. They actually have some benefit. So it's not just another make-do little task on the side designed by somebody else. You have to actually blend it into the workflow so it makes sense for clinical practice. Is what you have to do. It all depends on where you're standing or sitting as you look at the problem. And the argument I'm really making is you need to look at it from the standpoint of the teams who are delivering the care.
If I could ask one follow-up to that, and this is based on comments in the chat, that it seems as though every organization uses the problem list differently. And there are even different regulations at the local level for who can document on the problem list. And it was noted that England has national standards for problem lists. Are there any thoughts around where perhaps we could go to more streamline and standardize the use of our problem lists?
This is Andy. I'm going to comment not in my federal capacity, but from 20 years as a CMIO and chair of the Medical Records and Informatics Committee at Dartmouth, where we struggled with this issue. And I think one of the real challenges is that not every clinical group has the same degree of commitment to maintenance, curation, and taking care of the problem list. And it takes very little for it to become unmanageable and therefore not usable. And without clarity around which problems are the same, many of you know me as a critical care doc. If I am at the patient's bedside and I describe the patient as having ARDS, and one of my colleagues is next to that patient and describes that same patient as having respiratory failure, and we put those in as problems, and if David Bates, who I respect greatly's decision support, fires off the ARDS component, but not the other component, you can sort of see where there's a problem. So I think there is a technical issue that has yet to be adjudicated and resolved that could make the problem list way more effective than it is today in many clinical settings.
I've got an idea on that too, Sarah. If I were approaching this as a quality improvement problem, I'd do something called key process analysis. I'd identify the big heavy-duty processes that had the biggest impact on my patients and their lives. And it turns out it really narrows it down. When I first did that at Intermountain, I started with more than 1,450 clinical conditions, inpatient, outpatient, 104 of them. 7% of them accounted for over 95% of all of our care delivery and all of our care delivery outcomes. What I would strongly recommend is that you carefully select which items you really want on the problem list. And frankly, I'm not sure I'd put ARDS there. It's too small. You see what I mean? But I would try to get high leverage for things that matter.
Yeah, and there's a difference between an inpatient problem list and an ambulatory problem list that goes over time longitudinally in terms of improvement.
Well, we're having a great chat conversation about this question as well. And I think you guys have teed up that conversation, so thank you. Other questions, Sarah?
Absolutely. There was a question about if there is or could be an effort to align documentation requirements across settings. For instance, nursing homes and home health have very different requirements. based on assessments and reporting requirements than acute care facilities. Aligning these could help with consistency that could impact quality and safety.
There's actually an active project going on to do that, looking at the various assessment tools, looking at the common data elements, looking at both the element itself, but how the element is supposed to get reported as well, and trying to align across them. I believe it's called the PACIO project, PACIO project, and it's a couple years in the making. As part of that project, or as a related effort, because of the alignment that they're trying to achieve, but also because of what they've learned, they were able to start taking away certain elements of the assessment tool itself. So they're trying to make the assessment tool shorter, but not just to make it shorter, but also so it's truly relevant to what's going on for the patient. So you can track them. So the problem with the current state is you can follow a patient goes from sniff, 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 and you can get an idea of how they do across that setting. But when they go to different settings, you really lose track of functionally how the patients actually do.
Thank you. And again, there's been a little bit of chat about this. Susan Hall and others have put the link into the PACIO project on the chat for those of you who have an immediate interest in digging into that. Thank you, Mary. Other questions? It looks like we still have 3 more minutes.
Great. So yeah, there was a question about, can we talk instead of reducing burden, eliminating burden, and eliminating documentation requirements for billing or quality overall, instead pulling the data that administrators need from the record directly.
So I'm going to start with Andy. I have a feeling everybody has something to say about this one.
Oh, yeah.
I will say that there have been tons of head nods about this question, Andy. So what do? Let's just stop the burden. What do you have to do?
So I am now speaking as Andy, not as government.
I'm definitely taking the CMS off my background next time around.
So part of our thinking when we came forward with the burden report was to actually make that recommendation. To basically say that what belongs in documentation is basically what you need to take care of the patient, what you need to remind yourself if you're doing longitudinal care when the patient comes back to you, what a third party would need to take over that care should you be unavailable, or what consulting clinicians would need to care. And then who defines that content? Right now, you know that various third parties, including Mary's large organization, define some of that content. We proposed ONC and CMS in some of our discussions to actually dramatically change that. Now, that was pretty controversial. Those of you who remember a couple of years ago, there was some pushback from an organization that describes itself as the House of Medicine when we came forward with a proposal that basically said, look, we're going to blend all of these fee-for-service ambulatory things into a single thing. We're going to adjust it so that it's revenue neutral, so that no one gets hurt. And then you put in the notes what you need to care for the patient. Now, that's a little bit of an exaggerated summary. And we didn't get that fully across the goal line, but what we did get across is the changes that went into effect a couple of days ago, which is that you don't have to do all of the items in the history of the present illness, in the physical exam, and the review of systems, that you could take advantage of content elsewhere in the record. That's a substantial change, and that hadn't been changed since 1997. Now, I'm personally going to suggest that we are on the road to get to exactly what you talked about.
I'm going to stop you. Thank you. That is wonderful. Mary, Mary, please. Do you have anything else you'd like to add?
So I agree that the ideal is to be able to get information from the record itself, but we just described how the record is messy. And so the question is, how do you actually get to that information? And I think that's a problem to solve. It's not something that should prevent us from going down that path.
Thank you. Brent, you have the final word on this one.
You know, in trying to do clinical improvement at the front lines, clinical management for ideal outcomes at lowest necessary cost, we realized that IT played an absolutely essential role. We designed a data system to do that. It ended up to be really a compiler, a train complete compiler that was designed to layer on top of a services-oriented architecture. We treated existing EMRs as SOAs. Some of them actually have the hooks relatively in place to do this. It was based around care process models, originally the key idea that drove quality improvement. What we showed was that it reduced your vocabulary. When you're working inside a single activity, for example, Andy, with ARDS was one that we looked at. You went from hundreds of thousands of terms to about 5,000 terms. NLP started to work at a very high level, 98, 99, 100% level, because of the reduced vocabulary. It meant that
So
the
Brent,
computer could understand what you're saying.
Yep.
Well, the short version is I think we need a complete new design of how we think about these systems. It could work dramatically better. It's a design issue.
Yep.
And we need to design with that in mind. So thanks.
Thank you. That was great. So I want to once again thank our first three panelists